Good evening, everybody. This is Dr. Nidhi Khandelwal from Mumbai. It's my great honor to host this particular webinar today, which is basically a collaboration between IAGES and ALS-GBI. As you all are very well aware that these two societies are doing tremendous surgery, and one of our fortes is making sure that everybody gets to train and learn a little bit more about this field and all the possible applications of it. Now, one of the things where minimal access is being widely used is, of course, the field of colorectal diseases. And because we can have such a wide variety, there can be a different approach, there can be different thought processes, we decided to keep this particular webinar today. So I welcome you all, and to begin the proceedings, I would first introduce the president of IAGES, that is Dr. Subhash Agarwal. Sir, if you could just say a few words.
I'm Dr. Subhash Agarwal, President, Indian Association of Gastrointestinal Endosurgeons. I'm basically based in Delhi, and I'm heading Department of Surgery and Minimal Access Surgery at Sri Balaji Action Medical Institute, Delhi. So, IAGES and ALS-GBI, our collaboration with this basic aim is that whatever we do, when we interact with each other, is basically sharing our experiences and educating people so that in minimal access surgery, we move forward, and ultimately what is latest, we should know how we can train our surgeons. That's what we in IAGES are doing. And we are going to every nook and corner of the country. And now we have collaboration with SAARC countries, like and webinar we are having with SAARC countries as well as ALS-GBI. And our approach has been whatever the experience we have the one of the best talents available in India. So we always like to exchange the experiences so that we become wiser, and ultimately is the patient who gets the benefit of it. And that's what for which we are here today. Nidhi.
Thank you so much, sir. I believe the president of ALS-GBI has sent us a short video. So could we please have the video? Dr. Selvasekar will be running the video for us, and he has an important message for us at the end of the video.
Yeah, very important message. Let me just play the video first. Welcome, everyone. This is a fantastic collaboration we have got between IAGES and ALS-GBI. Our president, Professor Tan Arulampalam, has sent a message, so let me play the message. Thank you. Thank you, Nidhi.
Hello, and welcome to this joint ALS-IAGES webinar. The friendship and academic partnership between our two associations has been so rich, and I am very grateful for all of those who have worked so hard to put on these events. I think things will only get stronger between our two associations, and I look forward to many more webinars to come. Thank you very much, and enjoy the webinar.
Okay, great. I've stopped sharing. Welcome everyone. Thanks, Nidhi, for helping with organizing this webinar series. From ALS-GBI, it'll be Mr. Graham Whiteley who will moderate the session. But before we go on to the webinar, I just want to sort of use this as a plug-in to introduce our ALS-GBI annual meeting, which is in Derby from the 5th to the 6th of November. There is a session for IAGES on the 6th of November, which is also joined by the president of the IAGES, Dr. Agarwal, and few of his colleagues from India. So we want this to be a regular event going forward. There is a robotic training day and also a laparoscopic training day on the 2nd and 4th of November, respectively. And this is a meeting which where we focus on advances in robotics and in minimal access surgery using either the laparoscopic approach or the robot, and to advance the training, focusing on training and improve the patient outcome. So welcome everyone. Hopefully see a lot of IAGES and ALS-GBI delegates who are logged in today at the annual meeting. Thank you, everyone. Thanks, Nidhi. I shall let you introduce the moderators. Thank you.
Thank you. So with that preamble, let's just move on to the actual session. Joining me is my co-moderator from UK, Mr. Graham Whitley. Mr. Graham, would you just like to say a couple of words before we kickstart this program?
Hello, everybody. Welcome to the webinar. My name is Graham Whiteley. I'm a sturgeon from North Wales. At the moment, it's raining, and I hope you have better weather than me. It's a great pleasure to be a moderator with my colleagues in India. I trust it's going to be, as the other webinars have been, a great success. So, Nidhi, thank you. Over to you.
Thank you so much. It's raining out here in Mumbai too, and we're enjoying it a lot. So we'll move on to our first speaker, who is a consultant surgeon from India, Dr. Deep Goyal. Those of who are here in Indian minimal access surgery circles, nobody needs an introduction to who he is. He can do absolutely anything with the laparoscope or else with the robot itself. And today, sir is going to talk to us on laparoscopic right hemicolectomy, CME CVL D3 resections for right colonic cancer. Is there a difference? So over to you, Deep Goyal, sir.
Thank you, Nidhi. Thank you, everybody, for joining us on a weekend. And as you all know, that India has reached the final of T20 World Cup, so very eagerly waiting for the match. So I will quickly try to finish this. So as you all know, that right colon cancers and right hemicolectomy is a very common procedure for any surgical department, and a lot of changes have happened in last decade. The way we do it, we have taken a concept. Okay. God. Now the slides are not moving.
It was moving earlier.
Yeah, they were moving. That's what technology can do to you.
I absolutely agree. Tech challenges never cease.
So could you check in the right bottom corner? Left bottom corner.
Left bottom, I can see the arrows there.
Okay.
So forward.
From here. Yeah. Okay. Yes. Thank you for help. Okay. So this diagram is just representing different embryological planes which exist in abdomen while we consider this procedure and how we can go through these planes. So Hohenberg was the first person from Germany who introduced the concept of CME, and he took a leaf out of TME, and which we practice in rectal cancer, and dissection into the embryological plane to completely remove the envelope of the fat around the vessels, which contains lymph nodes which drain the tumor. And you tie and ligate the vessels, vein and artery right at the origin. And also you need to have sufficient length of bowel resected to complete the oncological principles. If you just see this mesocolic anatomy, how the different planes are fusing. If you see deep subperitoneal fascia is fusing with mesenteric root, right fusion fascia of the TAT. And if you go and if you remain in the right embryological plane, they are completely avascular and they ease the procedure. Also an important point, if you look at the root of the mesentery where the dissection has to start, it's very important to look at a particular angle. So if it's a perpendicular angle, that's what you want to do. If you look at an oblique angle, you will probably go into the wrong plane. So that's again a very important point to remember. Coming to the vascular anatomy, I haven't seen any other anatomy so varied after hepatobiliary tract. You find so many variation in the venous drainage in this area, and it is important for us to know if we want to clear complete lymph nodes with the mesenteric fat envelope here, because if you are not aware of these variations, they can lead to torrential hemorrhage and they can cause a lot of problems. So I'm not going to go into the detail, but just to let you know that one should be aware of all these. So this yellow diagram is showing that which area of lymph nodes we need to dissect while doing the surgery. So there's a concept of surgical trunk of Guillot. If you see this diagram, around 44 millimeter of this area, which starts cranial side of the ileocolic vein to the most caudal side of the loop of Henle or Henle's trunk. All the fat around this area needs to be taken out as an envelope. So that is something which we need to remember. And this diagram on the left is showing D2 lymphadenectomy. That is when you ligate the vessels at the origin and remain away from the origin and take all the lymph nodes. But if you come on the ventral surface of the vein and go onto the left edge of the vein and clean all the mesenteric fat there, then you are talking about extended nodal dissection or a D3 dissection. That is what we are talking about today. And this diagram, again, Japanese are very fond of numbers. And if you have to see on the right side, D3, lymph node station 203, 213, and 223 is something which we need to remove. This is 203 right at the origin of ileocolic, 213 at the right colic, and 223 at the middle colic origin. So this envelope around this needs to be removed. And that is the concept of D3. If you talk about surgical approach, we all know that we can go lateral to medial, medial to lateral, which was very preferred up till now. Tunnel approach, which I am very, very fond of. Bottoms up and top down represent if you come from up, that is you open gastrocolic ligament first and come down, or if you do tunnel approach, that is called bottoms up approach. So there is some evidence to suggest that if you do tunnels approach, there is a lesser blood loss and operative time is also lesser, but otherwise there is no difference in the results. Patient's position, again, is a matter of personal choice. I normally stand in between legs, but surgeon can stand on the left of the patient. Patient can be supine or lazily lithotomy, depending upon your comfort level. What is important today, like any other procedure, is that today our quality of surgery is measured by a pathologist. The pathologist can look at the specimen and tell you what kind of surgery a surgeon has done. So if constantly we are not performing well, then there is a red flag that we need to retrain ourselves. And if we talk about CME D3, there can be 3 types of reporting: when there is an intact mesocolon, or there are significant mesocolic defect, or there is a significant and extensive defect exposing the muscularis propria. So that one needs to remember that you are being looked at constantly and your quality of surgery is being judged. This is a specimen. I'll just show you picture by picture. These are the ileocolic vessel area. This is the surgical trunk of Gilliot. This is the superior right colic vein. This is the gastrocolic trunk of Henle, right branch of the middle colic. And that area represents the D3 lymphadenectomy. And this is called a complete mesocolic excision. So all these points are reported by a pathologist. So again, why interest in D3? Today we know there is good evidence available which shows that oncologically D3 lymph node dissection is actually superior, and it increases survival to some extent, but more importantly, it decreases the local recurrence and disease-free survival. This is a systematic review of around close to 6,000 patients, and it very clearly shows how much local recurrence is with CME D3, and the 5-year survival has increased to up to 99%. So as I was saying, there's a lot of literature available. I'm not going to go into the detail, and it very clearly indicates that oncological advantage is there with this particular procedure. This is just a small video to show how technically we do. This is a robotic platform, XI platform. And after going in and doing a diagnostic laparoscopy, we are tautting the ileocolic vessel and now trying to score the mesentery close to ileocolic origin and then extending it to the superior mesenteric vein and artery. The beauty of this platform, the robotic platform, is 3D vision and control of camera with surgeon stability and angulating instruments. You see how you can see that we can angulate our instruments at joints and go into every nook and corner. And after we expose the duodenum, you see the ventral surface of the head of the pancreas, all the nodes being taken there. And this now we are lifting, going into the retroperitoneum, coming back to the pedicle of the mesenteric vein. Another good point, my colleague standing outside is telling me that probably I'm more medially, I need to come little laterally, and probably he was right. And you can see that we can already start visualizing the superior mesenteric vein. And if you see, we are taking away all the fat and the lymph nodes from the ventral surface and to the left edge of the vein as well. So once we have done that, we are moving towards the medial edge or the right edge, and you can see the superior mesenteric artery in the picture, because as we are lifting the fat up, the artery is coming into view from posteriorly, and that's the SMA and SMV. So gradually we take away all the fat along with it, and any significant size lymphatic we clip, otherwise we use. Another point to notice is that we are not using any advanced energy source. It's all monopolar cautery in the robot. That is possible. It's probably because of the very precise and close vision that you are dissecting and cutting fiber by fiber. You see how gently the tip of hot shear is doing the dissection. So all the fat and the lymph nodes being taken away. And now we're gradually moving towards the ileocolic pedicle. Again, taking utmost care of not to damage the major vessel. Now we are working on the ventral surface of the pancreas. That's the loop trunk of Henle. And that's the duodenum you can see. Again, a significant lymphatic being clipped and cut. You can see the ileocolic pedicle artery and vein together from the origin, and you can see behind the head of the pancreas. Now the left hand comes into play. It gently lifts up the fascia and the fat on the vessel, so we can dissect the vein and artery off from each other and make a window. So see how gently with the movement of wrist, you can push your way through into the planes. That's the vein and the artery. And then once we have cleared the nodes at the origin, we clip them. All the lymph nodes are going towards the specimen side. And there's some more fat here, which we realized. So we are dissecting that again. And that's the origin of the artery. Again, the hinging of the instruments is so useful and so friendly. All this fat being taken away into the specimen side. And then you put a clip again, as I was discussing. And you cut it. You can see that all the fat has been taken away from the anterior surface of the pancreas. Now we are coming towards the middle colic pedicle. And there sometimes can be so much of variation that sometimes the right side branch of the middle colic will come directly from the main vessel. Sometimes it gets branched to common middle colic and then branching. Here we had an aberrant vessel, and you can see here now middle colic, main pedicle dividing into right and left. And we clip them. After we do this, that's the main job which we're trying to do. And now we are dissecting the transverse colon away from the duodenum. And once that is done, we open the gastrocolic ligament, and you can see this epiploic loop of Henle, epiploic vessels and loop of Henle. So one has to be very careful here. And now mobilizing the hepatic flexure. And then piling the stapler. Since this was a cecal growth, we are doing a classical right hemi. And then all the other attachments, lateral attachments being taken away. And then we come down, score the mesentery close to the bowel, small bowel where we need to resect. Some people can do that in the early part of the procedure and then fire a stapler. And then we do intracorporeal anastomosis, taking 2-0 silk to get two ends together. These are stay sutures. And once you have taken two stay sutures, you can pull them apart to give a proper traction and move them into desired direction, which is convenient for you to fire a side-to-side, stapler to do a side-to-side anastomosis. One can use a robotic stapler, but we decided to use the endoscopic staplers in this particular case. And once you've done the anastomosis, you see this. And then closing the mesenteric defect as we do in open or laparoscopic surgery. So that is my presentation. So to conclude, I would say that CME CVL-D3 results in higher number of lymph node harvesting, and it correlates for node-negative disease in increased survival. It results in a removal of intact envelope containing all the potential routes of metastatic spread, and surgical disruption of this package can lead to worse survival. This procedure offers best chance of eradicating the lymphatic metastatic process. And thank you very much. Improved local relapse rates are due to complete removal of intact mesocolic fascia, and it improves distance recurrence rates due to ligating the vessels at the origin, and it allows standardization of surgery for colon cancer and improves the quality of surgery. After initial learning curve, complication profile is same. There's not much difference in literature. And I will end by quoting the famous quote by Charles Darwin, that it is not the strongest of the species that survive. No, it's the most, not the most intelligent, but the one which is most responsive to the change. Thank you very much for patient hearing.
Thank you so much, Dr. Goyal. That was, I must say, that surgery was just so beautiful, practically bloodless, and just that joy of watching the SMA and SMP being completely clear. I think as a surgeon, it was just one of the best sights that you can ask for. Mr. Graham, do you have any questions for our speaker?
I have no questions. I'm very impressed, Dr. Deep. I think we can all learn from that demonstration. Excellent. I thought it was a great video. So it's not all talk. You really can do the job. And I think one of the things, if I may ask you, people have a fear of the Henle's trunk. Have you any advice to us as to, for the not merely the robotic surgeon, but the laparoscopic surgeon doing this? Have you any advice for us as to how to master this?
Yes, that's a very good question, Graham. And I would caution everybody that everybody should think that in this particular case, the bleeding can happen. I have to avoid it. So bit by, if you're used to, like I'm basically used to a bottoms-up approach, but a lot of purists would like to do a top-down approach, that is opening the gastrocolic ligament first, and then identifying the trunk of Henle, and then being careful, taking the gastroepiploic close to the stomach and moving forward. But as long as you are aware that this structure is there and it is very unforgiving, you have to be careful. I would just say that. And clip any large size vein which you come across, please clip it on the either side and then cut it. Don't be don't be too heroic and using energy sources and taking these veins, because that can be disaster. Once you injure these veins, what you don't realize that you will have to take stitches to control it. And when you take deep stitches, what you are going to do is compromise the vascularity of the small bowel, because you will probably tie off the mesenteric vein, and that can be a disaster.
Yes, thank you for that, Dr. Eid. I think we have Nada Francis on the line who may want to ask a question. Nada, are you there?
Yes, I am, and I'm just agreeing that I enjoyed the presentation. Fantastic demonstration. The question is I ask all the time is training and teaching this operation and make sure that it's done safely, because when we see the experts doing it, it seems seamless and without any problem. But for somebody, I'm talking specifically about CME, for somebody who's not familiar with it, it's the worry if they just watch a video or attend a course and they try to have a go at it. So what are your thoughts and what's your strategy about teaching this operation in a structured way to the learners?
I think that's a very, very valid thoughts and very valid question. As you know that, like we are a teaching department. So in our department, is when a new resident joins, he has to obviously go through vigorous training in anatomy and different procedures. They see a lot of videos. They become the second assistant if I'm doing a laparoscopic procedure, and then they become the cameraman. And that is how we gradually advance. And obviously, a lot of videos needs to be seen. Today, that part has become so easy. There are millions and millions of videos available on YouTube if you don't have your own. But in our department, we once in a week, we have a session where they present videos and we threadbare discuss the steps of a procedure and gradually handhold them to do the surgery.
Sorry, but going back and but for teaching this robotic, do you suggest, for example, like, do you have a dual console? They will start first with them.
We are very, very fortunate, Francis. Yeah. We in our hospital we have 3 XI robots, and one of the robots has a teaching console, and so that is how we take them through. But it is not available to us all the time in all the surgeries. I think in only 10% of our robotic surgery we use that console. And I'm afraid I work in a private hospital, and unfortunately we are not able to give our residents the robotic surgeries at present. But I guess as it happened with me that, you know, when I did my first robotic procedure, which was an LAR, and I always show that video in all the conferences, I did not feel even for a second that this is my first surgery. And the ease of doing a procedure was so good. So I'm assuming that if they see enough number of cases and they are aware of the anatomy, and they have done a significant number of laparoscopic procedures, I don't think there should be a problem when they move towards robotic surgery.
Thank you. You're absolutely right. The robotic makes it easier, especially for this advanced surgery. Me did it laparoscopically. It was very, very stressful, and it's much easier done. Yeah. One final question is about what are your thoughts in terms of preoperative planning, in terms of the anatomy and vascular blood supply and trunk Henle? Do you have a strategy like reviewing CT scan? Do you have a model for reconstruction of the vascular anatomy before surgery?
Yes. So in our department, we do a triple phase CT for all these patients who come to us, and we do a reconstruction. Also, I should have shown that in my video, we do use a lot of ICG during the procedure, Firefly. So that also sometimes help us, not so much in the right colon, but more in the left colon. We use Firefly. That also can be used to identify the vascular pattern in that particular patient. But vascular reconstruction with the help of CT is something which is now becoming quite common in our department. I wouldn't say that we do that for all the patients, But if we are ordering a CT scan, our CT scan is a contrast triple phase CT, and we do make all the efforts with the radiologist to understand the anatomy.
Thank you so much.
Thank you very much, Francis.
Okay, that was excellent, and we had some really good discussions at the end of it. And I thank Dr. Deep Goyal so much for that wonderful presentation and that wonderful surgery as well. Deep sir, you spoke about ICG. So on the note of that, I'll move on to our next speaker, Mr. Ronak Chhabra from UK. He will be talking on minimal access management of chyle leak using ICG control.
Perfect.
Mr. Ronak, over to you.
Good evening, everybody. I'm just about to share my screen. Yeah, is the screen coming up? Yes.
Yes, sorry.
Okay. Can you all see my screen? Hello?
It's blank right now. If you could just move forward.
Yeah, I'm just.
Yeah, that's good.
We can see now.
Oh, yeah. So I'm going to discuss a case that was done along with one of my colleagues, Mr. Lorenzi, who is a consultant upper GI surgeon, for a patient who's had an esophageectomy. She had a persistent chyle leak, and we were running out of options of what we could do. And then we thought that we should do the surgery with ICG. And so essentially, let's firstly have a quick recap of what is chyle leak and why it happens after esophagectomy, just so that everybody's familiar with it. So it's not very common for a chyle leak to happen. It's quite low, the incidence about 3.5%, and most of the time it's self-limiting. So you more likely than not, for people who aren't doing esophagogastric surgery, they don't see it as often. The risk factors that sort of sometimes can be associated with a higher chance of having a chyle leak are patients who have a higher clinical TNM stage or extensive lymph node dissection. Now, both these things essentially, by common sense, actually take you that you have larger nodes or whatever, and everything that the dissection happens closer to the thoracic duct, or you take it in block in a disease segment, or you are close to the cisterna chyli. Also, if you have had preoperative radiation to the mediastinum, this makes the contraction of the thoracic duct a little bit weaker, and it's healing a little bit weaker, which can predispose you to having a chyle leak. And the Japanese also saw that a BMI of less than 25 can sort of predispose you to having a chyle leak because there's less of a fat cushion between the duct and the nodes. So there was a esophagectomy complication consensus which happened 2-3 years back, and they sort of divided the type of chyle leak. So based on treatment, they were divided into 3 types. Type 1 was the ones that responded only to having dietary modifications. Type 2 were the patients who required TPN to sort out the chyle leak, and type 3 were the ones who required some sort of intervention. They also divided based on the volume of chyle leak. Essentially, type A, which is less than 1 liter a day, and type B is more than 1 liter a day. And this is the classification essentially, which as soon as you tell somebody there's a chyle leak and you want to take advice, they will say, what is it, more or less than 1 liter? That's sort of unofficial benchmark. Now, while researching before this case, what to do and what are the protocols, I realized that everywhere you go, there is a different protocol, and there are about 2 or 3 systemic reviews that have been done. But at the end of it, they all say, there's such a variance in practice. People tend to do what they want to do. So this is just from one of them, where it says that, if you've got a chyle leak, essentially first thing you try is dietary modification, which could be with MCT feed, octreotide, or TPN. See how much the volume is. If it's responding, conserve. If it's not responding, do something more major. Now, what are the conservative managements? Now, it can vary from having a low-fat feed to just the patient having water, or having any of those with medium chain triglycerides, which usually tends to be coconut oil in developing countries like India, or peptidine feed in other countries. Also, you can give octreotide, and you can put the patient on total parenteral nutrition. Now, the puzzling thing that I would always think of as a student would be, why are we giving medium chain triglycerides? Won't that also come via the lymphatic channels? And only a few years back, when I was trying to get this answer, the answer to this question, I realized that these medium chain triglycerides actually get absorbed directly into the venous system and don't go via the lymphatic system because they're water soluble, and that's the reason you give them for nutrition, and they're very high in calories. With regards to octreotide, there's a wide variance of dose that people would give, but it is tend to be generally safe to give about 100 to 200 mics every 8 hours as well. So how would you sort of decide what to do? By a sort of rough guide, what you can think is, if the patient has less than 500 ml of chyle coming out per day, we can probably just try a low-fat diet. If it is between 500 to 1 liter, you probably try TPN along with only clear fluids. And if it is more than that, then you know what, you probably just need surgery to sort it out. Now, with regards to the interventions, you've got surgery and you've got radiology. Now, surgically, you can either do a thoracoscopy or a laparoscopy, or you can do a thoracotomy or a laparotomy, depending on what your primary surgery was. Also, there are different type of things you can do in either of them. You can do a mass ligation, which people who have tend to do a thoracotomy would do, because essentially you don't get great views in a thoracotomy, inside, but you do get them on a thoracoscopy. And so that's where you would then sometimes do a selective ligation, or, see what you're ligating much better. With regards to taking assistance from our radiology colleagues, there is also lymphangiography. Now, these aren't very commonly done, so every place has a different way of doing them. So you'll have consultant radiologists who will do a pedal lymphangiography, means they will inject between the toes, or they'll do intranodal one where they'll go to the inguinal nodes and inject the dye. Once they have done this, they can, if possible, they may sometimes do a coil embolization, which as per the case reports tends to have more than 90% success rate. Or sometimes, if they're able to isolate where it is coming from, they could guide you to what approach you should do for surgery, or they have also attempted to do pleurodiosis at certain points of times for this. Now, coming to our case, we had a 34-year-old lady who had a 2-stage esophageectomy. This was a robotic chest and a laparoscopic abdominal approach, and we tend to do a hand-sewn anastomosis for all our esophagectomies, which have been done completely minimally invasive. She had a leak of a chyle leak on 7th postoperative day, which is not completely uncommon for leaks to happen so late. And most of the chyle was coming through a left pleural drain, which we tend to put transhiatally, which comes out from the abdomen. The volume was quite low. It was about 200, 300 ml. So we tried a conservative approach initially with TPN, clear fluids, and then octreotide. We tried this for about 2 weeks, which is sort of the recommended time, and it stopped. But when we resumed fat in her enteral diet, it sort of automatically came back. We then went in for a diagnostic thoracoscopy and a laparoscopy post ingestion of cream, and there was a suspected site in the chest which was sutured. But unfortunately, this failed. Subsequently, we thought after a few days we'll put an NJ, give her adequate amount of cream, and then see which drain actually pours out the chyle more, and then we'll go into the chest or the abdomen selectively first. Unfortunately, even 4 hours after the cream was given through the NJ, There was no chyle seen, and she ended up having a chyle leak the next morning, very funnily. So we then sort of went back to the drawing board and figured out a better way of doing it. We contemplated if she should probably go somewhere else for an embolization, but then because we had a robot and we had ICG camera associated with it, we thought let's go ahead and try it with ICG. So this is just a short video about how we have done it. So, a 35-year-old lady had a persistent chyle leak after a robotic two-stage resectectomy. Previous conservative and standard surgical techniques had failed. I was injected in the submucosa of the proximal jejunum approximately 20 minutes before the surgical procedure. A robotic-assisted right thoracoscopy was performed. The stomach tube was mobilized anteriorly. Thoracic duct was visualized under infrared light. A minor leak was seen below the previously applied clip and suture. 40 PDS switches were placed close to the thoracic duct to control the leak. Additional stitches were taken along the course of the thoracic duct to ensure that the duct was completely obliterated. These stitches were taken in a figure of 8 fashion. The camera was frequently swapped from normal to infrared vision to ensure correct placement of stitches. A total of 3 stitches were taken for satisfactory obliteration of the thoracic duct, after which the area was irrigated with saline. There was no active chyle leak seen on fluorescent imaging further. A drain was placed close to the site of the leak before beginning the abdominal part of the procedure. A robotic-assisted laparoscopy was then performed. The lesions around the stomach tube were divided carefully to expose the hiatus and the anatomical region of the cisterna chylae. On swapping the vision to infrared, a bright green fluorescence was seen in the chylous fluid accumulated behind the stomach tube, which signified an active chyle leak in the region. After washing out the area, an active leak was identified in some branches of the systemic chylae. The branches of the systemic chylae were then ligated with 4 to 0 PDH stitches carefully. Frequent washout and swapping vision to infrared mode was used to ascertain the need for additional further stitches. The use of the Da Vinci robot helped in precise suturing of the chyle leak compared to a traditional laparoscopic approach. The post-operative pathology of the cancer was YP-P3-M3-M0. It showed extensive nodal diffuse, which is a well-known risk factor for developing chyle leak. A total of 4 stitches were taken around the system of highly to control the leak. The use of ICG for helped us precisely identify the exact site of the persistent leak in this patient who had previous unsuccessful surgeries for control. Some centers practice radiological embolization of the thoracic duct, but this facility was not available at our hospital. No further kite leak was noted for suturing. Pistol glue was applied to the area of previously seen leak. Chi leak was successfully controlled by clipping of the thoracic duct as well as cisterna chyli under ICG guide. The patient was subsequently discharged after a few days. So yes, so that's it from my side. Yes, let me stop sharing. Yes. So thank you.
Great. Thank you so much, Mr. Ronak. I think these cases can be really harrowing. They can cause a lot of sleepless nights for everybody on the team. And having the robot over here is definitely a massive advantage. I mean, of course, ICG is the one which helped you localize the leak, but using it on the correct platform is also very important. And
Yes.
especially the Firefly and Firefly sensitive mode definitely just, add more flavor to the mix. Mr. Graham, over to you.
Right, Bill. Thank you very much indeed. Now, Ronak, thank you for that. Interesting, but worrisome complication. I like the way you emphasize the importance of the volume of chylous leak in making your decision to do something. You did mention that octreotide you used for 2 weeks in general. Is there any benefit in using it for longer?
There is, so when you're doing the conservative approach, that's when it is of any value of using the octreotide. Essentially, you don't want to be waiting after 2 weeks on a conservative approach if things aren't improving. So if things are improving, you could sort of stretch it a bit longer, but if things don't improve, you have to go in and do something. And once you've operated, essentially, you don't need the octreotide.
Yes, so I agree with you. What proportion of your patients with chylous leaks need surgery? And if they do, what determines whether you refer them for radiology or surgery? If there's some intervention which has to be done.
So I can tell you in the past, so we work at a tertiary esophagogastric referral center for Essex. In the past year, I think we've had 3 chyle leaks, and this was the only one which needed sort of anything more after a second operation. So that's essentially when you start thinking, do they need embolization? But we did think of it, and we were sort of in the process of getting in touch, but then we stumbled upon this approach, which made more sense. And we have to sort of even see the human factor, where our patient, she was young and she then went to complications. She hasn't been home for so long, so they do get depressed, and transferring them to another center to do something, though it sounds technically fine, is not not as reasonable in the human sense. So if we can do it, we do. And now I think the next patient who was referred from the ENT surgeons who had a leak, we directly went in and used ICG at the first go, because let's be honest, ICG doesn't take much to do if you've got the right camera. So you might as well just do it as a sort of standard procedure the next time you're dealing with them.
Very true, and it seems to be increasing our use of ICG in a number of conditions. I have to sympathise with you. Day 7 is usually the leak day for any anastomosis, and we all fear it. Well, thank you very much. I enjoyed that talk. Anyone else online wishes to ask a question?
Just a comment, Ronak. I think excellent video and excellent the way you managed it. As everybody has said, they can be harrowing, and these patients very quickly go into catabolic state, and so that's something worrisome. And most of the time, as you mentioned, in our department, in our institute, we do take help of intervention radiologists, and most of the times they are able to help us.
Yes.
Well, thank you very much indeed. So our next speaker is Dr. Anup Singh. Nidhi, would you like to say a few words to introduce him?
Yes, absolutely. So we've heard from the senior surgeons already on our team, and it's time to move on to our trainee surgeons so that we can see the world from a slightly different, more perspective. Mr. Anup Singh is a DNB surgical gastroenterology resident working with Dr. Deep Goyal himself, and he will be speaking on locally advanced rectal cancer and the role of total neoadjuvant treatment. Anup, over to you.
Yes, ma'am. I am sharing the screen. 1 minute. Are you able to see the screen?
Not yet.
Not yet, Anup.
Now?
Yes.
Yeah. Thank you.
Okay. I am sharing a case, locally advanced rectal cancer and the role of the TNT. Here, a case of 29-year-old female. She presented with complaint of bleeding per rectum from 1 month and altered bowel habit from 1 month, particularly grossly progressing and constipation and tenesmus. Her abdominal examination was normal, and on rectal examination, perianal area was free from any redness, skin tag, and anal tone was normal, but a hard circumferential growth palpable at the tip of the finger with no blood staining. On routine investigation, hemoglobin, total leukocyte count, platelets, serum creatinine, INR, and LFT were normal. And on the then we proceed on the colonoscopy, there was the circumferential ulceroproliferative growth causing the luminal narrowing at 10 centimeter away from the anal verge, and the endoscope was not able to pass from the growth, and a biopsy was taken from that, and the histopathology report was the signet ring cell carcinoma, and CA level was normal. She was evaluated with the PET-CT. All these investigations done from the patient coming to us. So when we she was first evaluated with the PET-CT, which revealed a circumferential irregular mural thickening in the rectosigmoid region, particularly in the upper part of the rectum, in the rectosigmoid junction, and there was the multiple lymph node in the mesorectum and in presacral area. She was further evaluated with the MRI, which revealed circumferential irregular mural thickening in mid and upper part of the rectum, and that is 8 centimeter away from the anal verge and around 9 centimeter in the length. And entirely, it is abetting the lower part of the uterus. On the axial cross-sectional imaging, here we can find the rectal growth that is in the anterior part. It is abetting the anterior peritoneal reflection, and in a more upper part, it is in the abetting the uterus. There were the multiple presacral and mesorectal lymph node. So the clinical stage was the T4 and 2. She received treatment in the form of short-course radiotherapy and 4 cycles of the FOLFOX. And then she reassessed with again CT scan and the MRI. On the CT scan, we can see there was not much improvement in the tumor, and tumor is still present there. And even on MRI, we can see the MRI tumor regression grade is 4. A lot of the tumor is present, and there was a poor response of the treatment. So she present to us. Here we can also find the lymph node, those shrink in the size, but multiple pre-cycle and the mesorectal lymph node were present. So she came to us. So what option we have next? In the previous treatment she received, so the MSI testing was not done. So considering the poor response to chemotherapy and the advanced rectal tumor, and that is the signet ring, and that is also as 20 to 25% of the patient has progression of the disease during the chemotherapy. So first is the MSI testing, and if MSI high, we can give the immunotherapy. Second, continue same treatment of the chemotherapy for 5 more cycles as in the rapido arm. Next option is the surgery at this stage. Considering the poor response to the chemotherapy, and we can consider the anterior pelvic exentration. But considering surgery at this stage may results in any complication of the surgery may keep away the patient from the chemotherapy, and during this period, patient may have the systemic progression of the disease. And next is the second line chemotherapy, addition of oxaliplatin to irinotecan. We now considered in this particular scenario, we send the sample for the MSI testing, and we'll decide if it is MSI high, we will give the immunotherapy, and then consider the response. And if it's come like MSI low and microsatellite stable, then we will continue the more cycle of the chemotherapy. But here is the part we could have done different if the patient present as to the early. Definitely we should do the MSI testing and consider the possibility of the immunotherapy and TNT from the beginning. So what is the TNT and total neoadjuvant treatment, and what's the role in the locally advanced rectal cancer? In the last 1 decade, the total neoadjuvant treatment in the advanced local cancer is now become the standard of the care. But previously, the traditional standard of care is the neoadjuvant full course, long course chemoradiotherapy of 5.5 weeks, 50 gray, and then surgery, and then adjuvant chemotherapy. The neoadjuvant treatment, we are delivering both chemotherapy and the radiotherapy before the surgery. So what are the advantages of the total neoadjuvant treatment? First, the full dose of the chemotherapy given early in the course of the disease, which may address the micrometastasis. The primary rectal cancer is more responsive to the FOLFOX than the metastatic disease. So if we give the chemotherapy early in the course, we can address the disease at early stage. And the rapid symptomatic relief seen in the most of the patient is with the first dose of chemotherapy. And the stoma requirement is for the shorter duration of the time in the TNT. In the previous approach, if we do the surgery and then patient has to manage stoma for 6 months of adjuvant chemotherapy, and that is very difficult for the patient. The patient is requiring stoma. Here we can close the stoma just after 2 months of the surgery. And in carefully selected patient, and we can apply the wait and watch approach. So the role of total neoadjuvant treatment start from the Polyps 2 trial that included only 3 cycles of the chemotherapy. But the main role of the TNT comes from the Rapido and PRODIGE 23 trial. Rapido trial has 2 arms. They included around 900 patients. All were T4 and 2. They had high risk. They included high risk patients. Those were T4 and 2 extramural invasion and mesorectal fascia invasion. Around 50% of patients has at least 2 or more high risk features. And among they randomized into experimental arm and the standard of the care. In the experimental arm, they deliver a short course radiotherapy for 5 days, and then the chemotherapy for 18 weeks. Most of the patients were given the capox regime of the 6 cycle, and a small number of the patients given FOLFOX, and then after 2 to 4 week surgery, and the standard of the care 5.5 week of chemoradiotherapy, then after 8 week surgery, and then after 8 week 6 months of the chemotherapy. Recently in 2020, there is a 5-year outcome of this Rapido trial have published. So the primary endpoint was the disease-related treatment failure, which include local recurrence, distant metastasis, death of the patient, or onset of the new colorectal cancer. So the disease-related treatment failure were significantly less in the TNT arm, and the distant metastasis was also less. But the local regional failure rate was higher in the experimental arm, and there was no difference in the overall survival. So basically, this TNT regime provided the better systemic control while compromising the local control. If we see in the local regional failure in depth, we found that the oral local regional failure was higher in the experimental group, but this was more significant. But the local regional recurrence has 2 components: the early local regional failure, which means the R2 resection or unable to do the surgery, and the local regional recurrence. So the early local regional failure were the same, but the local regional recurrence rate was the higher in the experimental arm. That was significant because the mesorectal breach was in the 21% of cases. So this is probably because of the neoadjuvant long duration of the chemotherapy, making the mesorectum fragile. So the next important trial came the PRODIGE 23 trial, which included T3 and T4 tumor, and it in the experimental arm they have given FOLFIRINOX 3-month chemotherapy, then standard long course chemoradiotherapy, then TME, and then the adjuvant chemotherapy of 8 weeks, and the standard of care 24 weeks. And the long-term outcome of the 5-year of the PRODIGE 23 trial also improved disease-free survival, metastasis-free survival, and overall survival significantly. So in the TNT treatment group, we have a concept of induction versus consolidation chemotherapy. In the induction chemotherapy, we give the chemotherapy just before the radiotherapy to sensitize the cancer cell for the radiation. Chemotherapy is given in the low dose, but in the consolidation chemotherapy, we give chemotherapy after completion of the radiation, so we get longer duration of the waiting period. So to compare which approach is better, CEO, ARO, and AIU, this is a German trial. They compared the induction versus consolidation, and they included FOLFOX before the radiation and after the radiation, and they found that there is no differences in 3-year disease-free survival, local recurrence, and distant metastasis. But pathological complete response was significantly more in the consolidation chemotherapy, and consolidation chemotherapy was also associated with the less toxicity. Now, recently, the PROSPECT trial also published. They included total neoadjuvant treatment, 1 hour without the radiation therapy. They randomized the patient into the long course radiotherapy, then TME, and then adjuvant FOLFOX, and the other arm was only the FOLFOX, and then the reassessment. If there is a response, then the TME, and there is no response less than 20% of the tumor, then the radiotherapy is given. This trial also revealed that in the FOLFOX group, 9.1% received only the required to preoperative chemoradiotherapy, and in the they concluded in the locally advanced rectal cancer, preoperative FOLFOX was non-inferior to the chemoradiotherapy. So now the TNT is trying to shift without the radiation in the rectal cancer. So now the clear indication of the total neoadjuvant treatment is the advanced tumor T4 disease, N2, mesorectal fascia involvement, and extramural vascular involvement. In this patient, we should consider total neoadjuvant treatment. Thank you.
Thank you so much.
Presentation. Sorry, Nidhi.
No, sir, please go on. I was going to ask you to speak anyways.
I think nice presentation, Anup, summarization. As we all know that as more and more chemotherapeutic agents and immunotherapies are coming into play, we are realizing that a selected group of patients will be benefited, and there will be significant number of patients where organ can be preserved by using these newer drugs and immunotherapy along with radiation plus minus. So I think this is the future where we are going, because we know that preoperatively tolerance of chemotherapy is far superior as compared to postoperative use. So I think we are moving towards more and more use of TNT in a significant number of patients. What are your views about this, Graham?
Well, I absolutely love the changes in chemoradiotherapy which have happened over my experience at senior level over about 35 years. In the old days, we used to do examination under anesthesia in all patients. If the tumor was tethered, they got short course radiotherapy and operated on the next week. If they had a fixed tumor, they got long course chemoradiotherapy and were operated on some 10 to 12 weeks later. And the development of the combination of chemoradiotherapy over the years and now immunotherapy has absolutely revolutionized things. It's brought science into what used to be an art.
Thank you. Any other comments from anybody? Silva, would you like to make a comment, or anybody else?
Yeah, thanks very much. I thought that was a fantastic presentation. Thanks, Anup. I just missed, did this patient have MSI stable, or did you not measure that?
Oh, no, we are waiting for the reports. We received the patient after receiving the short course radiotherapy and 4th cycle of the chemotherapy, and the MSI testing was not done previously. So we are waiting for the report. Recently sent.
We only got the patient, Silva, after all this treatment was done outside. So we are sort of now resetting the whole protocol now.
You know, I thought that might be the reason, because she's 29, and if you have the MSI, if it is a wild type, then you would go to what you did. Otherwise, you would do the immunotherapy at the moment. And there is enough evidence to suggest that most of these are now completely melting away with the immunotherapy treatment with less side effects. So yeah, no, thanks very much. And so is there any family history for this patient?
No, sir, there was no family history.
Thank you. Thanks. And the thing is, there was a pelvic meeting last couple of days, Thursday, Friday. They're moving the TNT, especially in this patient. I think, obviously, you guys have not done it, but it would be a long course chemoradiation rather than a short course. If you're looking for a shrinkage, there's no, it doesn't help just to doing a short course. But anyway, just a sort of a thought. Thank you.
Fantastic. I believe Dr. Subhash Agarwal sir wanted to say a word. Okay, fine. So we'll just move ahead to our last speaker. We've had a lot of malignant discussion so far, so let's move on and on a little happier and more benign note. So Miss Mishal from UK will end the session with benign colorectal polyps.
Hi, I'm going to share my screen now. I'm afraid there have been some very high yield, incredible cases discussed, but I'm going to talk about some boring stuff. Please let me know if you can see my presentation.
Yes, it's visible.
Lovely. So essentially, I'm going to be talking about colorectal polyps, mostly benign stuff. But the idea behind benign disease is trying to figure out what's benign so that we know what's not benign, and then to try to, escalate the patient appropriately and manage them as needed. I think I'm going to be speaking more from a junior trainee point of view, who's just starting out in scoping, and I often find that come across a polyp and then a million things going around in my head to say, how do I explain what this is? And I think that was the kind of that was what I was hoping to talk about, and to try to figure out a more streamlined way as a trainee to try to kind of dissect what type of polyp we're looking at, and then what to do with the patient from there. So I'll be talking about a case. We had a 67-year-old patient, very fit and well, completely asymptomatic, took part in bowel screening, from which was invited to have a colonoscopy as part of the bowel screening program in the UK. And this is what we saw when we went in the cecum. When I looked at it, I was lost for words for a bit. I said, I don't know, what do I say? It's a big, large, lumpy thing in the cecum. I don't know how I would even describe this and how I would, go on to then further investigate and manage this patient. So at the time, a biopsy was taken with me and my consultant and images, and that was all we did. We're going to talk a little bit about how there's quite a lot out there about different classifications for polyps, and reading into a lot of the work that's been done, the idea around from studies from Canada to the US, across the waters into Australia, everyone kind of agrees on the top yield or high yield kind of classification tools that are recommended. So I think the first most important thing is where the polyp is. So it kind of just it's not always easy to tell in a colon for a junior trainee, but we now have the kind of guides to let us know where we think we are. But it's a good idea to say where something is to start with. And then the next thing would be to kind of talk about what size the polyp is. Diminutive or less than 5 millimeter polyps they are the majority of all polyps that we encounter. They are the boring ones, usually benign ones, and very low risk of them progressing into cancer. Smaller polyps between 6 and 9 millimeters do have potential to become malignant disease, and they can include adenomas. And larger polyps, more than 10 centimeters, excite everybody because they have the highest risk of becoming cancerous. So just the size of a polyp itself can give us a hint as to its malignant risk. We'll talk about the Paris classification, which is one of the commonest ones that we use. So essentially, any lesion is divided into polypoid and non-polypoid lesions. We have pedunculated lesions, subpedunculated and sessile lesions, and in non-polypoid lesions, which are usually less than 2.5 millimeter elevated off the mucosal surface, are then subdivided into flat elevated, flat mucosal change, mucosal depression, or ulceration or excavation. We look at some pictures of what you might see. So on the top left, you can see classic pedunculated polyp with a stalk, quite easy to describe, small, medium, or large, depending on what you see. A subpedunculated polyp, the bottom, and on the right side, you can see a sessile polyp. These are images of what a flat elevated and a mucosally depressed polyp look like. And yes, I know our eyes are already trained to identify and to know that these automatically are more worrying. And I used to look at these lesions and think, yes, I know that if this is a more worrying lesion than a little pedunculated polyp, but didn't know how essentially to go about and describe it. So the Paris classification tells us that a 2C or a mucosally depressed lesion is of concern. The 2A or the depressed lesions are then further subdivided in a category of lateral spreading tumors. And these are further subdivided into lateral spreading tumors, which are either granular homogeneous, granular nodular mixed, or non-granular flat elevated, or non-granular pseudo-depressed. And these are again some examples of what a granular homogeneous may look like on the left, and a more mixed lesion on the right, which has both granular elements at the back and more nodular, prominent nodular feature at the front. On the left, you can see a non-granular flat elevated lesion, and on the right, you can see a non-granular pseudo-depressed, because the middle section does look like it is depressed. And again, our trained eyes know that these lesions are more concerning than polypoid lesions. What's important to remember at the Paris classification is it technically applies to polyps of the entire GI tract. It's also a more descriptive kind of classification, and that helps you look at a polyp and figure out what properties it has when you look at it that are more predictive of invasive disease. For trainees, it's often difficult to characterize these lesions, but especially the ones which have mixed elements to them. So we'll often see reports where a lesion has been described as having two different elements, which could be a 2A or 2C features. And then higher risk features, as our trained eyes already know, larger lesions, lesions which are depressed, and non-granular lesions are more likely to have malignant potential. This then helps guide the decision for whether a certain lesion would be suitable for endoscopic resection versus formal operations. The up-and-coming thing in colonoscopy, which in the East has been used for quite some time, is narrowband imaging. And there's more research coming up now to tell us that narrowband imaging can be extremely useful, especially for junior endoscopists who are trying to characterize a lesion and to understand whether this is a benign or a pre-malignant or indeed a malignant lesion. Narrowband imaging essentially is a filter in front of your scope. And what it does is it filters out certain wavelengths of light. It highlights the wavelengths that essentially absorb hemoglobin or are absorbed by hemoglobin rather. And what this ends up doing is it makes the microvasculature within your lesion more visible. And this in turn helps us to identify abnormal angiogenesis of lesions that are dysplastic, which we might not be able to see with the naked eye or with the scope. And the narrowband image often with your colonoscope gives you a magnified view of the lesion as well. And there's you can see just on the bottom what a difference it makes when you switch from your kind of optical normal resolution to a narrowband image. We'll talk a little bit about NICE guidelines from 2009 that were then kind of improved upon to form the JNET guidelines of 2018. The NICE guidelines essentially kind of broke down lesions into type 1, 2, and 3, depending on what they visually look like. So lesions which were of the same color as the background or slightly lighter than the background are not as concerning, as opposed to maybe a type 3 lesion, which is brown or darker relative to the background, and you can maybe see patchy white areas. Similarly, with the use of narrowband, if you look at vessels or vessel patterns, you might not see any vessel patterns, or maybe an isolated small vessel in a benign lesion, as opposed to which a pre-malignant or a high-risk lesion may have areas where vessel architecture is disrupted. Similarly, there's talk about surface pattern, and white or dark spots, which are uniform and homogeneous, are less concerning than a kind of absent pattern or amorphous pattern. The type 2 in the middle was the one which caused a lot of confusion, in the sense that a lot of lesions which could be benign but could also have malignant potential would fall under this category. This essentially are lesions which could be browner relative to the background. You could see brown vessels surrounding white structures, oval, tubular, or branched kind of structure patterns surrounded by brown vessels. This is where the JNET classification comes in, because it essentially helps break down the type 2 lesions into a more benign lesion and into something which could be more pre-malignant. Essentially, this talks about vessel pattern again in much more detail, which is something you can only see really with narrowband imaging. Vessel patterns which are regular caliber, regular distribution, or more in a spirally pattern are less concerning than variable caliber vessels with irregular distribution, as you can clearly see on the narrowband imaging. Surface pattern, which is more regular, as opposed to surface pattern, which is irregular or obscure. And as you can see, these two lesions, the type 2A lesion is clearly a low-grade intramucosal neoplasia. However, the type 2B lesion is a high-grade lesion. Narrowband is highly specific. From research that has been done recently, we know that when we look at lesions which have been described as being 2A or 2B lesions under narrowband imaging, and when you compare that to their expected histology, it's been pretty spot on, which is really good for junior trainees and nurse endoscopists who might not be very trained or have a lot of experience as to what just looking at a lesion and knowing whether it is benign or pre-malignant. This is also important because 2A lesions can technically be removed endoscopically. However, 2B lesions are very variable and require further assessment. And this then takes us into a further kind of assessment of the lesion, which you can then talk about pit pattern assessment using Kudo classification, which we'll just talk about. And this then helps us figure out whether this 2B lesion is suitable for an endoscopic resection or whether a formal operation is required. We talk a bit about the WASP classification. So with the Paris classifications, with your JNet and your NICE classifications was all good and grand, but people thought that certain types of lesions were being missed out or misrepresented within these classifications, and these are sessile-serrated lesions. Historically, it was thought that adenomas are the only lesions that are precursors to colorectal cancer, but now we know that sessile-serrated lesions we think are the precursor to about 15 to 30% of colorectal cancers. Looking at the JNet classification, this often kind of misgroups these lesions as non-neoplastic when indeed they can have neoplastic potential, and this risks that an untrained endoscopist may think these are benign lesions and leave them in. Characteristics which are unique to sessile-serrated lesions are cloudy surfaces, indistinctive borders, irregular shapes, and dark spots inside crypts. These are two good images of what a sessile-serrated lesion might look like. To an untrained eye, the lesion on the left might look very benign, like a small hyperplastic lesion, when indeed it is a sessile-serrated lesion, which is something you can only see when you use narrowband imaging and you are aware of the specific characteristics of sessile lesions. The lesion on the right has this very unique cloudy surface as well, so that's worth noting. Coming into the Kudo classification, the Kudo classification dives even deeper and into even more magnification, and it essentially really looks at pit patterns on top of lesions, which kind of are easier to see when you use dye. So when it's graded from 1 to 5, and the 1 being most benign, as you can see, are round pits, which are not concerning. Stellar or papillary pits are non-neoplastic. However, as you start to go down into your type 3s and type 4s and 5s, you can see how the pit pattern changes. And on the right, you can see that branch-like or gyrus-like pits are of more concern. Irregularly arranged pits and different types of pits within one lesion is all of concern. And as you can see that as the lesion develops more malignant potential, the pit pattern changes and becomes more non-structural. This is just an example of a lesion that you'd see and how you might describe it. I think before kind of all these classifications, it can be quite daunting for a junior endoscopist to know, how do I assess this lesion, how do I describe it, and what do I do from here? The good thing to start off with a guide would be, where is it? So this lesion is in the sigmoid colon. How big the lesion is. If you look at the Paris classification, you can see that this lesion is flat elevated, but it also has a depressed surface, which means it is a 2A and 2C combination lesion. And then you've used narrowband imaging to look at the vessels on the surface, and you can see the architectural distortion of the vessels, which means that according to a JNet classification, this is a type 3 lesion. We don't have dye staining here, but it's you can expect that you might find a Kudo pattern 5, just looking at the architectural distortion on this image. And when pathology came back for this lesion, this was a well-differentiated tubular adenocarcinoma. You can see how the lesion, which might look benign to the untrained eye, with the use of all of your proper kind of classification tools and narrowband imaging, you can actually convince yourself that this is a more concerning lesion that needs appropriate management. Coming back to our patient, this guide now kind of gives me a better idea of how I describe this lesion. So I knew it was in the cecum. I can see that it is a large lesion over 3 centimeters, which automatically means I should be more concerned. Looking at the Paris classification, this can be described as a 2A and a lateral spreading tumor. And it has granular elements and more nodular elements, so it's probably a mixed. Unfortunately, the reality of the colonoscopic world, no narrowband imaging was available on this lesion, and no one thought to use dye. And I just thought how important that could have been to further kind of assessment of the lesion here. However, the patient underwent a CT scan. I think despite the use of narrowband and the Kudo classification, the person who looked at this thought, no, this is a very concerning lesion and I need to escalate this appropriately. The pathology came back as a tubulovillous adenoma with low-grade dysplasia. if this was a completely excised lesion, you would not worry. But this patient, the discussion with the MDT was that this lesion was not amenable to endoscopic resection, and the patient was offered a right hemicolectomy. And the final pathology for that is still awaited. Thank you very much.
Thank you so much, Ms. Michelle. Does anybody on our panel have any comments for her?
I think it was an excellent presentation, Michelle. And as we all know that the story starts from colonic polyps. So it is, it is imperative for all of us to understand the importance of catching them, reporting them, and treating them in time, and raising the red flags. So I think it's one of the very, very important subject from the point of view of any colorectal surgeon.
Yes, I'd like to second that, Michelle. I enjoyed that immensely, and going through the classifications in detail. Our bowel screeners are most adept now at looking at these polyps and classifying them, especially as the technology has improved, which I think has improved our ability to classify the polyps. A little question for you. Have you done your own audits, you being a surgical registrar, have you done your own audits on narrowband imaging that you have observed and the histological outcome in the specimens?
No, I haven't, and that's a really good idea. I think it's worthwhile noting, because I come across reports from all sorts of endoscopists, from a surgeon to a gastroenterologist to a nurse endoscopist, and actually, although I've not formally looked into it, it's very obvious that newer trained endoscopists and nurse endoscopists especially are probably pretty good at reporting these tumors, and it is often I find more senior members who are perhaps reporting them as they not using narrowband imaging so much. So I think there's now quite a lot of chat about training newer trainees and encouraging colonoscopists to use narrowband imaging regularly, as opposed to only if they're only because. So we're trying to promote it, I think, quite a bit. But I might just do that audit.
Thank you.
That
anyone else?
Oh, sorry. Please go ahead.
I was about to say something, yes, to compliment the speaker, Michelle, that well done. Just done is he did not mention AI, and there's a theme of you substify them, it does not categorize them. But there is an ongoing study which is utilizing AI for different polyps. It's called Classica by Ronan Cahill in Ireland. So I'm just raising that. Hopefully, we will struggle less once AI is in the market and they're adjunct to our tools in the endoscopy suite.
Okay, all points well noted, and I think that brings us to the end of this particular webinar. It's been very fruitful. I will just request Dr. Subhash Agarwal to give a few closing remarks from his end.
Nidhi, I think Silva wants to make a point.
Oh, sorry.
Raised hand, yeah.
No, thanks very much. I was about to say about the AI. I think Nader sort of mentioned it, because what we all look at is pattern recognition, and we are already seeing the Olympus one, which comes in sort of with a box which says there's a polyp there, so it helps us to sort of not focus too much and focus on those areas which it sort of hones us in, and we are not far off from. I think AI will tell us. Going forward, what polyps we need to take and what polyps we can leave behind. But for the first time, I think in UK and also in US now, they've shown that with the screening programs, with polypectomies, the number of cancers detected have come down, which is great, which is good for the patients. And I was really impressed with your MDT, because most of these MDTs would have said, this patient with a 3 centimeter, the gastroenterologist would be keen to take that off endoscopically rather than surgically. And that's always an area where, so how did you reach that decision making that this was, because most I've seen now gastroenterologist taking half of the right colon polyps, completely shaving it off, and saying that they're preserving that organ, which I'm not sure whether I will agree with, but you go with the flow. What are your thoughts on that?
So this patient actually had 3 colonoscopies just to assess this lesion, because the first person who saw it obviously realized they couldn't resect it. Took a few pictures, came out. The second person felt brave enough, so the patient who came back onto a different consultants list. They went in, had the same reaction, took some pictures, biopsies, and came out. And then they ended up having a third proper assessment. But I think the idea on all 3 was, even though it was on senior consultants, a senior gastroenterologist list, and then a senior consultants list, everyone, the endoscopists all came to the conclusion that they were not comfortable resecting this. This particular lesion was in this strange corner because it was extending from the ileocecal valve to the appendicular orifice. And there was one corner which, no matter what you do, you couldn't even see properly. So I think no one was brave enough to attempt to remove it, because I think it was very obvious that some of it was going to be left behind no matter what they did. So I think that's why they came to the conclusion that doing a colectomy was the right thing to do.
Thank you. Thanks very much.
Okay, fantastic. Dr. Subhash Agarwal, sir, if you would just like to give a closing comment.
Yeah, thank you very much for the wonderful session we had. All the senior faculties as well as the youngsters, they have presented very well. And the technology, using the technology which is available with us, whether it's ICG or the narrowband or whatsoever, naturally, it has improved the outcome. And I'm happy to see that all these technologies are being world over. Earlier, these were limited to certain centers, but now this technology is running so fast that everyone, whosoever wants, can have these. And we are also fortunate that in India, most of the centers now we have ICG with us, and every center is using, right from basic surgery to all the advanced, whether it's for the vascular, say, lesions or chyle or seeing the tumors, all we are using, or for, say, hepatobiliary surgery to see the bile ducts and all. We all are using this technology, and this has really helped us, as well as the diagnostic tools. So thank you very much. It was a wonderful session, and I hope in future, together, we do more and more webinars on different subjects. We are always open to that.
Oh, you got Ishwar as well. Thank you.
Dr. Ishwarmurthy, our past president, immediate past president, and he is endoscopist doing all sorts of endoscopic procedures which are being done by the gastroenterologist. He do all those procedures. Dr. Ishwarmurthy.
Thank you, my President. It's always a nice feeling to be with, interacting with the members of ALS GBI. As you can see, this is a collaboration we are going on for the last 4 years. And I really appreciate the efforts they have taken in the annual events. And every time we have been treated and we have given us separate session. This time also we'll be there with them in Derby. I think, Subhas, you are also coming with us. We'll have an interactive session.
I will.
And I wish Vishwanath and Selva and now the current President Tan and Graham Whiteley, all of them, I think we are very, very nice to interact. I think it is very good for our postgraduates on either country. That's why we always say these transcontinental webinars are very helpful, because their style of presentation, especially bringing the postgraduates to do a case presentation. From there, the learnings we have, it is a different structure. Our trainees are liking it a larger way, and this, when it be uploaded in the YouTube, it's been watched very nicely. And I really admire Nidhi and persevering this and trying to get this better late than never. I think this time we took some time to get the first the ALGBI IAGES webinar, but it's very successful now. In spite of the other end, our India is scoring close to 180. I think I was watching this one. To be frank with you, that is the reason I joined a bit late. But it is really wonderful to have you. You are firing from all tanks. Thank you.
My one eye is on the television, is right there.
Anyhow, nice. Thank you, Selva.
Thank you, everybody. Thank you so much.
Thank you. So we did score more than 180 viewers, of course. I will just end this by saying that it's been a wonderful session, and I think there were some great learning points with each and every talk, and each speaker brought their own individual personality to every topic as well. I will thank our president once again, Dr. Subhash Agarwal sir, our past president, Dr. Ishwara Murthy, and also the president of ALSGBI, Mr. Tan, although he could not join us. I will thank my co-moderator, Mr. Graham, Mr. Nadir, and also, of course, all the speakers, Dr. Deep Goyal, Mr. Ronak, Anup, and Mishal, both of you. More than anything, I want to thank Mr. Selvasekar. I think he was incredibly supportive and very, very patient with me while I was trying to arrange for this entire webinar. So thank you so much for all your efforts, sir.
Thank you. You did a fantastic job in organizing this. Very short notice. But going forward, I think we need to make it as a regular thing.
Yeah,
we will try and work on. I'm sure Graham will get something sorted. I like your night dress, Ishwar.
It's nice to see Graham Whiteley. We have a wonderful dinner in Portsmouth. I look forward to meet you all in Derby. Soon I'll be there with my family. See you with my daughter-in-law, and my son is also joining me. Selva, we will welcome all of you for a World Congress 23rd to 26th. I think we have a separate session for ALGBI Hugs webinar. So a lot more happening in October. Please put me in. The City of Joy. We want all of you to be there. Thank you.
Okay. Thanks, everyone. Well done.
Thank you, everyone.
Thank you.
Thanks, Nidhi, for the wonderful arrangement.
Thank you, sir.
Thank you.
Thanks,
Bye.
Graham.
Thank you.